Assalamu alaikum students. Today we are starting with the name of Allah, Bismillah ar-Rahman ar-Rahim, and I'm going to talk on an important subject regarding cutaneous cancer and the commonest cancers regarding the skin. They are squamous cell carcinoma and basal cell carcinoma. So, as I already mentioned, we are going to talk about these two important malignancies of skin all over the world, but also in our region, in Pakistan. And starting with the brief introduction, I'm Dr. Tahir Kamal, working as assistant professor in Department of Dermatology, Lahore General Hospital and Miruddin Medical College, Lahore. So these two cancers, squamous cell carcinoma and basal cell carcinoma, it is approximately 1% of all cancer deaths, and in incidence in our region, in Pakistan, is approximately, if we are considering cutaneous carcinomas, squamous cell carcinoma comprises around 51 to 53% cases, and basal cell carcinomas accounts for 40 to 42% of all cutaneous carcinomas. Remember, basically they occur in patients who have fair skin color and they have excessive ultraviolet exposure, cumulative high dose of ultraviolet rays. So although the deaths are rare with these carcinomas because they can be properly managed if they are diagnosed early, but still both of these carcinomas cause lot of deformities and morbidities. So morbidity rate is quite high with these two malignancies. Here is the picture of squamous cell carcinoma on here, and you can appreciate that there is a roughened border with the central ulceration giving you a black color, which quite mimics basal cell carcinoma as well, but you have to carefully look for the margins and the ulceration and differentiate it from the pigmented basal cell carcinoma. Dear students, as far as we are talking about etiology of squamous and basal cell carcinoma, it's quite complex, but I'll try to be very simplified. Actually, when skin is exposed to ultraviolet rays, there is a specific role of melanocortin 1 receptor in the pathogenesis of these cutaneous carcinomas, as well as role of alpha melanocyte stimulating hormone pathway, which actually they are involved in the repair of DNA damage through the transcriptional activity. And when these are affected by cumulative ultraviolet exposure, especially ultraviolet CA, because of the ozone effects, so there is down regulation of P53 genes, which are also playing role in the repair of the damage, and so proper DNA synthesis and repair is not effective in the long run, and ultimately leading to these two cutaneous carcinomas which we are discussing in our talk. Aggravating factors are different, like as mentioned, people with fair skin are more prone to develop basal cell carcinoma and squamous cell carcinoma, and these regulatory and repairing mechanisms are also affected in chronic ulcers, especially in cases of squamous cell carcinoma. A chronic ulcer can lead to ultimately to squamous cell carcinoma, and ultraviolet exposure is increased in people with reduced size of melanocyte, and sometimes melanin content is low. So these all factors lead to developing these two cutaneous carcinomas. It is to be remembered that there are certain lesions which might lead to squamous and basal cell carcinoma, and these are called pre-malignant cutaneous lesions. There are certain diseases of skin which are pre-malignant, and usually in the long run they lead to squamous cell and basal cell carcinoma. One of the conditions most commonly encountered, especially in fair colored people in skin type 2, 3 and European race, that is called actinic keratosis, and it is almost always present on sun exposed areas, especially scalp, forearm, dorsum of hands. It is a pre-cancerous skin lesion, and histologically it is characterized by full thickness involvement of the epidermis. Invasive cutaneous squamous cell carcinoma is differentiated from actinic keratosis by the invasion of basement membrane. So basement membrane is not involved histologically in cases of actinic keratosis by malignant appearing cells. So actinic keratosis, it is characterized by small scaly lesions, looks like small erosions covered by adherent scales, which can be peeled off if you scratch. So I'll just show you few of the pictures, which are the early lesions of pre-malignant cutaneous involvement of skin in the form of actinic keratosis. This is slide of actinic keratosis. You can see on the dorsum of hand, because this is sun exposed area, there are multiple small plaques which look like erosions with mild scaling over it. So they are smaller in size, the side, and little wet erosive plaques with superficial scaling which is not very adherent. So this gives a clue of actinic keratosis, and as I mentioned, it is present on sun exposed area over dorsum of hand, and especially scalp of fair colored people with baldness, because there is no sun protection. So as we are discussing pre-malignant cutaneous lesions, which can most likely lead to squamous and basal cell carcinoma, having same etiology and aggravating factors. Bowen's disease is an important pre-malignant skin lesion, which sometimes look like a single psoriatic plaque. It is psoriaciform in nature, and it is sharply demarcated, irregular border. Usually it is present as an erythematous scaly patches or plaques that later on may become hyperkeratotic, crusted, fissured, or rarely ulcerated. Bowen's disease may also occur on mucous membranes also, so that is something which you should remember. And as we are discussing pre-malignant condition, similar carcinoma in situ, when it arises on the glans penis, it is referred as erythroplasia of Queyrat, Queyrat, erythroplasia of Queyrat, and that is also a presentation in the form of erythematous, moist, smooth plaque, especially on the glans penis for longer period of time. So this is carcinoma in situ, presenting as single or sometimes multiple patches and plaques, just like quite similar to plaque of psoriasis, but scales are not that prominent, they are not silvery, and Auspitz sign is negative. Other features obviously negative. In case of Bowen's disease, we should go for biopsy to confirm Bowen's disease, which is also called carcinoma in situ. Carcinoma in situ can be effectively treated with, if it is smaller in size, with proper curettage, cryo, or surgical excision with 0.5, approximately 5 millimeter to 1 centimeter margin to be safe, or sometimes topical therapy like 5-fluorouracil can be used to treat Bowen's disease. This is a slide showing plaque of Bowen's disease. Clinically it's sometimes very deceiving, difficult to diagnose, but usually history of long persistent patch and plaque with indistinct borders, mild superficial scale but not responding to conventional treatments, topical steroids, emollients, etc. And as I mentioned, this is called carcinoma in situ, so it is persisted for longer period of time. But if we confirm our diagnosis with punch biopsy or elliptical biopsy, so Bowen's disease can be effectively treated with different treatment options, which we'll discuss in later part of the lecture as we come on to the management of pre-malignant and malignant conditions, cutaneous carcinomas. Keratoacanthoma is another cutaneous presentation in the form of pre-malignant lesion, which can lead to squamous cell carcinoma. It is relatively common as a low-grade tumor and originates in the pyrosebaceous glands, and closely it resembles squamous cell carcinoma. So we need to confirm it with biopsy, and sometimes even it is confusing in histopathology also. Keratoacanthoma is characterized by rapid growth over a few weeks to months time, followed by spontaneous resolution, which is an important clinical sign. In approximately around 4 to 6 months time, it can spontaneously resolute itself, and keratoacanthoma may progress rarely to invasive or metastatic carcinoma. It is quite rare for keratoacanthoma lesion to be invasive or metastatic. And as far as clinical presentation is concerned, keratoacanthoma are limited to skin. Lesions are typically single, solitary, and it starts as firm, roundish, skin-colored or reddish papule that rapidly progresses to dome-shaped nodules with a smooth, shiny surface and a central crateriform ulceration. So it's like looks like a volcanic volcano. If you see on the top of a volcano, similarly, it becomes a nodule with central ulceration. It is called crateriform ulceration or keratin plug, which may project like a horn. Most keratoacanthomas occur on skin on sun-exposed areas, face, neck, dorsum of upper extremities. Truncal lesions are rare, and skin surrounding the keratoacanthoma lesion is usually normal. So here is a typical picture of keratoacanthoma solitary lesion with well-defined margins surrounding skin is almost normal, but it's like a nodule with central ulceration and keratin plug. Dear students, please remember there are certain inherited or genetic conditions which can lead to squamous cell or basal cell carcinomas, or if I explain in other words, these children born with these diseases or genetic abnormality, they have a much greater chance of developing basal cell carcinomas or squamous cell carcinomas on sun exposed areas. And these are few conditions like Bloom syndrome. You can study further on your own, look into it, especially as I have mentioned here, xeroderma pigmentosum and Gorlin syndrome. So basal cell Never syndrome, they all develop basal cell or squamous cell carcinoma early. So talking about xeroderma pigmentosum, basic defect in this disease is in nucleotide excision repair system, leading to deficient repair of DNA damaged by ultraviolet radiation. And patients with xeroderma pigmentosum have found to have deficiency of endonuclease enzyme, which is involved in the repair of DNA after damage from ultraviolet exposure. Broadly speaking, there are 7 xeroderma pigmentosum repair genes. Xeroderma pigmentosum A through xeroderma pigmentosum G have different roles and different course of disease according to the genes and the repair genes involved in the repair of DNA after ultraviolet exposure. So there are 7 complementation groups, but just broadly, repairing patient tends to develop early freckles because of extreme photosensitivity, and in the first or second decade even small cutaneous malignancies like cutaneous basal cell carcinoma, squamous cell carcinoma, malignant melanomas, these all develop in patients with xeroderma pigmentosum. This is slide of patient, and the face is showing multiple lentigines, freckles, and these small melanocytic nevi can change into multiple small basal cell carcinomas and also into squamous cell carcinomas. So these patients require a lot of sun protection, and you can appreciate many multiple small rounded melanocytic nevi and freckles all over the face, with few of the minor porcelain like whitish scars also, which gives a clue that these lesions might have got ulcerated and then healed. So this is a typical phases of xeroderma pigmentosa. Now we separately try to explain both of these cutaneous carcinomas. First we'll discuss basal cell carcinoma. Basal cell carcinoma is a common and importantly it is locally invasive keratinocyte cancer, sometimes also known as non-melanoma cancer. It is most common form of skin cancer and is also called rodent ulcer or basilioma. Patients with basal cell carcinoma often develop multiple primary tumors over time. There are certain risk factors for basal cell carcinoma. Age is one of the important factors itself, with the fair type skin, as we already mentioned. So they are particularly prevalent in males because generally they have more exposure to ultraviolet radiation because of occupational demands and outdoor working. And then the other risk factor is inherited disease causing photosensitivity or any genetically based problem in which there is ultraviolet induced DNA repair defect, or previously tendency of cutaneous carcinomas, melanomas, excessive sunburn, inherited syndromes as we already mentioned, Basic syndrome, Gorlin, xeroderma pigmentosum, and last but not least in our region, exposure to arsenic, radiation exposure, or certain medications. And basically it is often caused by DNA mutations in the patched PTCH tumor suppressing gene, which is a part of hedgehog signaling pathway. There are also various types of basal cell carcinoma, and one must remember they have different course of disease, morbidity, or the clinical features vary. So we need to understand basically there are different types of basal cell carcinoma, and the invasiveness of basal cell carcinoma depends on the type. So first is we discuss is a nodular type of BCC. It is most common type of facial BCC. It begins as a shiny or pearly nodule with smooth surface. Sometimes may have central depression or ulceration, which mimic keratoacanthoma, which you can recall we discussed earlier in the discussion. And if you closely examine nodular type of BCC, there are dilated blood vessels across its surface. There is also sometimes cystic variant of nodular BCC with soft jelly-like content, and also micronodular type. So this is a nodular type of BCC. Then there is superficial type of BCC, which is more of a plaque type. It is most commonly in younger patients, and it is also present on upper trunk and shoulders. Very mild or slight scaling. Looks like thin and translucent, but important clinical sign, please do remember, is the rolled border, and there might be multiple micro erosions. Then there is murphic type of BCC or sclerosing type, usually found in the mid faces. It is scar-like plaque with indistinct border, unlike we discussed in superficial BCC where there is presence of rolled border. border in morphic type of BCC, it is indistinct. Looks like a scar-like plaque, central atrophy, or it is also has a poor response to treatment. So wide excision is required in case of superficial BCC, or morphic basal cell carcinoma, and there is also basosquamous carcinoma, mixed basal cell carcinoma and squamous cell carcinoma. Won't go into detail, but just remember, even both type of carcinoma can be present at the same time. So these are few words about different types of basal cell carcinoma. Now coming on to the initial clinical diagnosis of basal cell carcinoma and squamous cell carcinoma, we need to confirm our diagnosis, and certain procedures may be used to detect and diagnose basal cell and squamous cell carcinoma. To begin with, obviously, proper skin examination. Look for the color, the borders, the size, shape and texture, and obviously long history, not responding to conventional treatments, so that gives us clue. And going for confirmation of our diagnosis, biopsy is the key point. So all or part of the abnormal looking growth is removed from the skin, and it is viewed under microscope by pathologists to see if cancer cells are present. There are three main types of skin biopsy. Either it is shave biopsy. Sterile razor blade is used to just shave off from the surface of abnormal looking growth. Then we can use punch biopsy. You can see the punch biopsy. There is a punch biopsy needle of various sizes, 2 mm, 4 mm, 6 mm. So the biopsy, from using the punch biopsy, it is taken from the border, so normal skin can be included in that, so that we can easily differentiate. A special instrument called a punch is used to remove a circle of tissue from the abnormal looking growth. And last but not least, excisional biopsy. Scalpel or punch biopsy or shave biopsy tool is used to remove the whole or the entire growth if it is smaller in size. So according to the size of the tumor, punch biopsy needle is selected. As I mentioned, it comes in various sizes, and then we totally remove that lesion, approximately 3 to 3.5 mm deep, and keeping safe margin, which we'll discuss, around the lesion. It is totally removed. That is called excisional biopsy, or total or removal of entire growth. This is, I've already mentioned, excisional biopsy serves both purpose, for the diagnosis as well as for the treatment, because entire growth is removed. So in smaller size of basal cell carcinoma or squamous cell carcinoma, excisional biopsy can be an option, which proves both ways beneficial for the patient. This slide is showing various types of nodular basal carcinomas, cystic type, and then the borders is you can see in one picture, lower right side, there are rolled borders. So this is also a clue of basal cell carcinoma. It is not pigmented, but it is nodular type of basal cell carcinoma. This slide is showing morphic type or sclerosing type of basal cell carcinoma. Again, difficult to clinically diagnose, but we should suspect some atrophic patches and plaques with very mild scaling and ulceration. Sometimes obviously it mimics Bowman's disease also, but biopsy can confirm this sclerosing type of basal cell carcinoma. So approaching towards the management and treatment of basal cell carcinoma, there are different options. Just we'll discuss one by one, but overall idea depends, the treatment depends on size, location and type of BCC. So we have different options according to the location of basal cell carcinoma, its site, age, size of the lesion. So curettage and electrodesiccation, Mohs micrographic surgery, excisional therapy, radiation therapy with cryotherapy, photodynamic therapy, sometimes for smaller lesions even laser surgery with carbon dioxide laser and erbium YAG lasers, which are ablative lasers, and last but not least, topical medications. Now, after the diagnosis is confirmed, we'll just discuss briefly the treatment options. Treatment depends most importantly on the size of the lesion, obviously location, and very importantly type of BCC, which we have already mentioned, because that must be clearly identified, and treatment depends on which type of BCC is present on patient's skin. So different options include curettage and electrodesiccation, Mohs micrographic surgery, excisional surgery, radiation, cryosurgery, photodynamic therapy, even laser surgery, and topical medications. Curettage and electrodesiccation, the growth is scraped off with the curette. It is a very sharp instrument, ring shaped tip, which has got very sharp blade, and the tumor site is desiccated, and then we use bipolar lead or electrocautery needle to stop bleeding. It is used for smaller lesions, and ultimately leaves a mild round whitish scar. It is absolutely not a suitable option for advanced BCC or in high risk sites. Then comes the excisional surgery. Excision means the lesion is cut out and the skin stitched up. Most appropriate treatment for nodular type of BCC, infiltrative as well as morphic type of BCC. Please remember, once you are going for excisional surgery, you should keep safe margin. That should include approximately 5 mm margin of normal skin around the tumor. So please ensure first you should properly mark the lesion with the junction violet dye or any marking tool, and 5 mm margin of normal skin around the tumor, it is marked, and then incision is given, tumor is removed, and then it is stitched with primary closure. If the lesion is little larger at certain areas, especially remember on nose, then we may require a flap or skin graft. Further surgery is recommended for lesions that are incompletely excised. Cryotherapy is the treatment of superficial skin lesion by freezing it using liquid nitrogen gas. It is suitable for small superficial BCC on covered areas of trunk and limbs. It results in a blister that crusts and heals within several weeks, and it might leave a permanent white mark after treatment. The other option is the radiotherapy. Radiotherapy or X-ray treatment can be used to treat primary basal cell carcinoma or as an adjunctive treatment for if margins are incomplete. Mainly used if surgery is not suitable because of some medical conditions or poor healing response from the patient, maybe quite larger in size, or the site is difficult to be treated. Best avoided it in young patients. It's not an option, should not be a first option, and especially in genetic conditions which are already predisposed to skin cancer. Radiotherapy or radiation should not be considered because that can further aggravate progression of the disease and photosensitivity or radiation induced dermatitis. Typically, patient attends once weekly session for several weeks. It causes inflammatory reaction followed by a scar, but there is still, as I mentioned, there is risk of radiodermatitis, and late recurrence chances are high, and there might be formation of new tumors. So it is an option for larger tumors, and scars might get worse. Now I am going to talk about another effective therapy for non-melanoma skin cancer, that is basal cell carcinoma and very small sized squamous cell carcinoma even. It is called photodynamic therapy, and the basic concept is to apply a photosensitizing chemical 2 to 3 hours before exposing to ultraviolet light, and this interaction causes production of oxidant radicals which can destroy the malignant cells, and these photosensitizing agents are of different types, but commonly used is the amino levulinic acid, and as I mentioned, it is suitable for smaller size superficial basal cell carcinomas, and various treatment sessions are required, approximately 3 to 5 sessions with 7 days interval. So photodynamic therapy ultimately gives better cosmetic results also, and it is a good option in smaller BCCs. Now moving on to the treatment and management of squamous cell carcinomas. Briefly, we should keep various histological variants of squamous cell carcinoma, like verrucous carcinoma, which is an indolent, well differentiated squamous cell carcinoma. It grows slowly as an exophytic cauliflower like lesions, and it is usually associated with human papilloma virus infection. This is usually arise in the anogenital region or maybe oral cavity. Next is the spindle cell histological variant, spindle cell carcinoma, rare subtype of squamous cell carcinoma. Prognosis depends on the depth of invasion, and verrucous and spindle cell carcinomas are managed similar to more conventional squamous cell carcinoma. The other type which have clinically aggressive behavior is the adenoid pseudoglandular type, acantholytic adenosquamous type, and desmoplastic squamous cell carcinoma. So we have already discussed various investigations like biopsy or incisional biopsy, excisional therapy, punch biopsy. to differentiate firstly the various clinical variants and histological variants of squamous cell carcinoma. But important thing is the imaging. If we diagnose squamous cell carcinoma histologically, we should go for imaging to see the extent involving the other structures, bone involvement, deep soft tissue involvement, and lymphovascular invasion. If it is suspected, the imaging like CT scan or MRI, these are the important tools in imaging to evaluate the invasion and the depth of squamous cell carcinoma. 5 to 10% cases of squamous cell carcinoma, they metastasize, and especially there is tendency where there might be some radiation therapy done in the management. It can lead to spread, and chronic ulcers may also lead to squamous cell carcinoma. Regarding the active management of squamous cell carcinoma, obviously surgery is the prime option. Radiotherapy offer excellent cure rates up to 90% in smaller BCCs, and treatment approach must be individualized based on specific risk factors in patients and its characteristics for the most acceptable cosmetic and functional outcome. So we must keep in mind that ultimately we need to keep the cosmetic outcome, especially if it is present on face. The management of skin cancer is guided by the biologic and histologic nature of the tumor and its anatomical site, and it is always advisable to avoid radiation therapy in younger patients. Regarding surgery, localized squamous cell carcinoma are most commonly treated with surgery. Curettage with electrodesiccation is the alternative treatment option, in which we scrape away the tumor and deeply curate it. Curate and electrodesiccation is fast and cost effective also, especially in our region. But the drawback is in curettage that we cannot really assess the margin of the tumor or squamous cell carcinoma. Curettage is a better option for actinic keratosis or carcinoma in situ, like Bowen's disease also, and cure rate may be achievable to 90%. Excision with post-op margin assessment is the prime approach. Standard surgical excision followed by post-op pathological evaluation of margins are necessary. For low risk tumors, remember it is approximately less than 2 centimeter margins of the normal skin to be taken, and for higher risk tumors you can go above or more than 2 centimeter up to 4 to 5 centimeter normal margins are taken around the tumor. And Mohs micrographic surgery is ultimately a very good option, because chances of recurrence are lesser, because every area, every section is at the same time being histologically evaluated and look for any we are sure about that the margins after surgery are clear, and it is preferred for high risk squamous cell carcinoma. So as I mentioned, otherwise radiation therapy is a good option but not suitable for younger patients. Last but not least, again for smaller cell carcinoma squamous cell, we can topically apply 5-fluorouracil or another immune modulator, imiquimod. Imiquimod works through induction of cytokine production, especially interferon alpha and beta and interleukin 12. So this is Imiquimod, also a good option, but especially again it is suitable or must be taken into consideration in cases of carcinoma in situ. So these are the few topical therapy options, and last but not least, as we discussed, cryotherapy and photodynamic therapy, which we have already discussed in the management of basal cell carcinoma also, in which we apply a photosensitizing chemical and then it is exposed to ultraviolet exposure, causing production of oxidant radicals which destroy the malignant cells. So I've tried to just give a brief idea about these two common squamous cell carcinoma, and I really thank you all for patiently listening to this talk. I hope you are able to understand the basic concept, the approach towards the treatment, different types of squamous cell carcinoma. At least you'll be able to clinically suspect these two squamous cell carcinomas, these two non-melanoma skin cancers, which are the most common cutaneous carcinomas. So with this, I thank you all, and if you have any questions, you can approach me in the department, and we can further elaborate different aspects of these two common cutaneous carcinomas. Thank you.